everyone. I would like to welcome you to our today's webinar on hepatitis B treatment. I would also like to thank Sanjay Bhagani from the Royal Free Hospital at the UCL in London, that he took the time to present with us the information on hepatitis B treatment. Welcome and thank you, Sanjay. My name is Christian Jachnovich. I am ETG Training Coordinator and I will moderate today's webinar. This webinar is organized within the context of the Hepatitis Access Needs Project, HAND, that ETG is currently running. And within this project, we are organizing 3 webinars. The first webinar on hepatitis C treatment has been organized on the 12th September. Now we organize a webinar on hepatitis B treatment, and you can already save the date for the 3rd webinar on hepatitis prevention. All webinars are recorded, and the recordings are uploaded on our website, www.etgtrainingacademy.com. There you can also find other interesting webinars and also the recording of the hepatitis C webinar. Today we will do it like this, that Sanjay is first presenting, and then you will have 15 to 20 minutes time to ask your questions. You can ask questions by either typing them in the question field, or you can also raise your hand, and then I can see that you raise your hand, and then I can unmute you so that you can speak in the microphone. Okay, Sanjay.
Thank you very much, Christian. Welcome, everybody. My name is Sanjay Bhagani. I'm an infectious diseases and HIV physician at the Royal Free Hospital in London and a senior lecturer at UCL in London. So over the next 40 minutes or so, we're going to talk about hepatitis B and specifically focus on treatment. Next slide, please, Kristen. So what I want to cover for you in this afternoon is a little bit about the epidemiology of hepatitis B and some of the peculiarities around the epidemiology of hepatitis B. One of the most difficult things, I think, for people is the virology and the life cycle of hepatitis B, and I will spend a little bit of time explaining that to you, because I think that's the platform on which all of the kind of issues around natural history and treatment is based on. We'll then go through the natural history, disease, and staging for hepatitis B. We'll clearly talk about treatments and treatment-related outcomes, and then we'll try and finish off today with the whole new exciting area of cure agenda and new therapies that are going to be coming to us in the next 5 to 10 years. Next slide, please. So let's start at the beginning, and those of you that were on Jürgen Rockstroh's broadcast the other day, he already showed you this slide. This is the WHO global mortality data from 1990 and then again in 2013. And as you can see from here, that viral hepatitis is becoming an increasingly more prevalent cause of mortality globally compared from 1990 to 2013. Next slide, please, Kristen. So if we then try and home in a little bit on this with regards to whether this is Hep A, B, C, or E, we can see this very recent publication looked at disability adjusted life year rates and changes in age-specific disability adjusted life year rates according to the different viral hepatitides. You can see from here it's very obvious that the biggest increase in viral hepatitis C related morbidity and mortality is in fact associated with hepatitis C rather than with hepatitis B. And in terms of the other two hepatitis viruses, so A and E, in fact there has been an overall reduction in morbidity and mortality. And so, you know, you were right to concentrate on hepatitis C at the moment, but as we move into the next 5 years of effective DAA-based therapy for hepatitis C, hepatitis B related morbidity and mortality will become increasingly more important. Next slide, please. So this map is looking at global mortality from viral hepatitis by viruses again. And here is where we start to see the real differences. As you can see in Western Europe and the United States, it's the red bit that is the most prominent on the pie chart, which is hepatitis C related mortality is very much more important. But as you start to move into sub-Saharan Africa, Southeast Asia, and the Indian subcontinent, you can see that hepatitis B becomes an increasing contributor to mortality in the context of chronic viral hepatitis. Next slide, please. And so this is the most recent data from the WHO Global Hepatitis Report 2017. This is looking at global prevalence and incidence of hepatitis B. As you can see, the chronic hepatitis B infection in children under the age of 5 has reduced drastically from 5% down to around 1%, and much of this is down to immunization. And so remember that you know, unlike hepatitis C, hepatitis B and hepatitis A are both vaccine preventable viral hepatitis, and so immunization becomes a key bit to what we do in terms of tackling hepatitis B. Clearly, we won't cover immunization today. This is a subject for a future seminar in October, but that's when we'll try and cover hepatitis B immunization in a little bit more detail. In terms of global prevalence, it's estimated that there are probably around 260 million people living with hepatitis B around the world, and that 3/4 of this probably live in Africa and Southeast Asia. As you can see down in the bar graphs, at the bottom is the African and the Western Pacific region that account for the most chronic infections with hepatitis B. Next slide, please. And so in order to understand hepatitis B, we really need to understand its life cycle. I make no excuses that this is a really complicated life cycle, but this is the basis on which we think about all therapeutics for hepatitis B. So unlike hepatitis C, hepatitis B is a hepatotrophic virus. In other words, it only can multiply in hepatocytes and has no extra hepatic sanctuary sites, unlike with hepatitis C, where there are other cells outside of the liver that may harbor hepatitis C replication. As you can see, this virus is very much like HIV in that it gets into the host nucleus and remains in the host nucleus as a template for viral production. So very much like HIV, the key here is the CCC DNAs, the 2 red circles that you see inside the host nucleus, which is like the mini chromosome, which once it's infected the cell, remains in there for life and becomes a template for new viral production. So this is again very similar to HIV, which actually integrates into the host genome. Whilst hepatitis B doesn't integrate into the host genome, it actually does get into the nucleus and remains there for the remainder of the life of that hepatocyte. The rest of the cycle is quite complex, but it involves a number of different processes, one of which is the HBV polymerase, which turns the RNA into DNA, and this is the bit that you see at the bottom, where the brown semicircle is turned into a double-stranded DNA, and this uses an enzyme which is very similar to the reverse transcriptase that HIV uses. And so this is the reason why nucleosides, certain nucleoside analogues, are able to stop replication of hepatitis B. As you can see, as part of that pathway, is that if you block that enzyme, you're only blocking one very little bit of the viral replication pathway. In other words, other things are still happening whilst you're blocking the polymerase activity. So, for example, on the left-hand side of that cell, the production of S antigens, so these are the envelope proteins S, M, and L, often remains unhindered with the blockage of the polymerase. And so, whilst we think about hepatitis B treatment with the nucleoside analogues that we've got at the moment, this is in effect very ineffectual therapy for hepatitis B. Next slide. And so, very much like hepatitis C, hepatitis B is not a single genotype, but we now recognize that there are different genotypes of hepatitis B labeled A to E. This is the global distribution of the genotypes. We're still in the process of learning about the different impacts of the different genotypes on the natural history of liver disease progression and on response to therapy. There are some things that we've learned already. For example, genotype D viruses have more predilection for having E antigen negative disease. We know that genotype A viruses, for example, are more responsive to pegylated interferon, but there is much more that we need to learn about the genotypes in hepatitis B. And as we start to get new therapies coming on board for hepatitis B, the genotypes may well become very important in the future. So this is just putting a marker down for people wanting to learn about hepatitis B, is that there are hepatitis B genotypes very much like hepatitis C genotypes, that these may be of great clinical importance, especially when we start to think about new drugs in the future. Next slide, please. So, just coming back to the clinical aspects of hepatitis B, the modes of hepatitis B transmission are very similar to paraenteral viruses in that spread is primarily via exposure to blood and bodily fluids. It does require a break in skin or mucous membrane, but remember that the virus is also found in semen, saliva, vaginal mucus, and in tears, but at levels a lot lower than in serum, and that some of this may be responsible for transmission. So there is a phenomenon of household transmission of hepatitis B, which is quite common, and we think that some of these other fluids may be responsible for this. What is really important about hepatitis B is that it is not found in urine, sweat, stool, or even breast milk. Next slide. So the outcomes of exposure to hepatitis B in terms of whether one spontaneously clears or one becomes chronically infected is very much dependent on age. And so if you're exposed to virus at a very young age, then you're likely to get chronic infection. The older you are at exposure to hepatitis B, the more likely you are to clear virus spontaneously. So here what I've done is I've shown you a graph of age at which one gets exposed and the risk of chronic infection, as you can see on the left-hand bar in blue. And then on the right-hand bar is symptomatic infection. So as one gets older, you can see the blue line coming down. The risk of chronic infection becomes less and less and less. And there is a turning point at around the age of 13, 14, 15, where you then become like an adult, where your risk of chronic infection is vastly reduced. Now, as you can see up on the left-hand side at the top, that the infection in Asia and Africa is predominantly transmitted either from mother to child or through children horizontally in early childhood, and because these neonates or children get exposed very early in life, they're more likely to get chronic infection than when you get exposed to hepatitis B in adult life. And it is for these reasons why hepatitis B is so predominant in sub-Saharan Africa and Southeast Asia, because the vast majority of infections turn into chronic infections, unlike in Western Europe and the United States, where the most exposure is in adult life and the vast majority clear virus spontaneously. And next slide. And so this then explains the geographical differences in epidemiology and clinical characteristics between hepatitis B in North America and Western Europe versus Asia and Sub-Saharan Africa. And so endemicity is high because the age of infection is younger in Asia and Sub-Saharan Africa, and so there's more likely to result in chronic infection. As a result of that, the risk of cirrhosis is much higher because of prolonged infection, and the risk of hepatocellular carcinoma is much higher because of prolonged carriage of infection. And so in terms of morbidity and mortality, this becomes a particular problem both in Southeast Asia and Sub-Saharan Africa, both as a result of end-stage liver disease and hepatocellular carcinoma from hepatitis B. Next slide, please. And so if you then look at the hepatitis B disease progression in this cartoon, you can see that once acute infection progresses to chronic infection, then there is a risk of progression to cirrhosis, which can then lead to liver failure and decompensation, and ultimately resulting in either death or liver transplantation in countries where liver transplantation is available. One of the peculiarities about hepatitis B, unlike hepatitis C, is that chronic infection without cirrhosis does lead to a risk of hepatocellular carcinoma. So in hepatitis C, hepatocellular carcinoma only arises in patients with advanced fibrosis or cirrhosis. In hepatitis B, it can occur without end-stage liver disease, or in other words, without cirrhosis. And this is one of the big enigmas of chronic hepatitis B infection. Chronic hepatitis B, up until recently, used to be a leading cause for liver transplantation. With the advent of good nucleotide-based therapy, the number of patients coming to liver transplantation for hepatitis B has reduced drastically over the last few years. Next slide, please. And so then in order to understand the diagnosis of hepatitis B and staging of disease in hepatitis B, one needs to understand a little bit about the blood and serum markers in hepatitis B infection. Unfortunately, this is something that is very poorly understood even by fully qualified doctors, but let me just take you through this in a little bit of detail. So the first and most important marker that one needs to use in terms of diagnosing chronic hepatitis B is the hepatitis B surface antigen. This is a marker of chronic hepatitis B infection when found in serum for more than 6 months. In other words, when people are exposed, have the acute infection, if they're not going to clear the virus and it's chronic hepatitis B ensues, then it's the S antigen that remains positive. And so if we're going to use one test to diagnose chronic hepatitis B infection, then it is this test that one needs to use, which is the hepatitis B S antigen. Anti-HBs or antibodies to hepatitis B S antigen is a marker of immunity to hepatitis B. This is the antibody that often comes up with vaccination for hepatitis B. E antigen is an E protein that is produced by the virus when it's replicating actively. It's an index of active viral replication and often is associated with very high levels of HBV DNA. And so in the olden days, we used to talk about being E antigen positive as a marker of high infectivity. Now, there are some viruses that continue to replicate at high rates but have mutated so that they no longer produce E antigen, and so these are called pre-core co-promoter mutants, which, despite having high HBV DNAs, will be E antigen negative, and I'll explain this in a little bit more detail in the next couple of slides. Antibodies to hepatitis B E appear in the recovery phase and is often absent in the reactivation phase, and again I will explain to you this in a little bit more detail in the next slide. Anti-core antibodies is a marker of having ever been exposed to hepatitis B. So patients with both chronic hepatitis B or previous exposure and clearance of hepatitis B will have the anti-HBc antibodies present. There is an IgM and anti-HBc that we can use as a marker of more recent infection. And then clearly HBV DNA is a bit like your Hep C RNA viral load or your HIV RNA viral load. It's reported in international units per mils rather than copies per mil. Next slide, please. And so when one thinks about chronic hepatitis B infection, so once people have been exposed to hepatitis B and they fail to clear virus, there are 4 phases of infection that one can go through. So most children will enter chronic hepatitis B infection in that first phase of infection, which is called the immunotolerant phase. This is the phase at which you have no immune response to hepatitis B, and this is the reason why most children get chronically infected with hepatitis B. So remember that the damage to the liver in hepatitis B is mostly immunopathological. In other words, it's your immune system trying to clear the hepatitis B that causes damage to the liver and inflammation as a result. And so in the immunotolerant phase, there's very little immune response to hepatitis B, so there's minimal inflammation, minimal fibrosis, very high levels of HBV DNA because it's replicating unchecked. As the children get older, their immune systems start to kick in, they start to recognize hepatitis B, they move on to that next phase of infection, which is called the immune clearance phase. This is where the virus is now trying, the immune system is trying very hard to control viral replication, and as a result it's attacking hepatocytes or liver cells that harbor hepatitis B. This results in chronic active inflammation, so very high ALT levels, fluctuating HBV DNA levels as the virus and the immune system try and fight each other. And if you're successful at coming through this phase, you then move on to the next phase of infection, which is called the inactive carrier stage. Now, the success of immune clearance is, as you see on the top, E antigen being lost and antibodies to HBe appearing. And so this is the crucial bit of your immune control of hepatitis B to move you into the next stage of chronic infection called the inactive carrier stage. Here, whilst you're still infected with hepatitis B, your immune system has taken control over the virus. There is now mild hepatitis and minimal fibrosis, low levels of HBV DNA, normal serum aminotransferases or liver enzymes, and these people are at the least risk of end-stage liver disease. Unfortunately, for some of these people, you often then move on to the next phase of infection, which is called the reactivation phase, and you will see on the top, you still remain anti-HBe positive and you don't make E antigen. So this is the so-called E antigen negative reactivation of hepatitis B, where the virus is now mutated so that it produces new virions without producing E antigen, and so escapes immune control. And in fact, these are people who are much older because they have come through all the other phases to reach the reactivation phase, and they probably have a lot of resultant liver damage before they reactivate virus. And so these are people most at risk of decompensating as a result of end-stage liver disease. Next slide, please. And so you can put this down. It's the same as the last slide, but you can call this a circle. And so this is often the circle of hepatitis B that we go through. As you can see, in the middle of the circle is hepatocellular carcinoma, and there's risk of hepatocellular carcinoma at each of those 4 phases of hepatitis B. So the question that we then ask ourselves is, where does HIV fit into all of this? And as you can see in the light brown boxes at the side, HIV has an impact at each of these stages of the natural history of chronic hepatitis B. And so if you acquire hepatitis B in adult life, if you're HIV positive, there is an increased likelihood of becoming chronically infected rather than clearing virus. And then at the chronic active phase of hepatitis B, these patients have much higher viral loads and increased fibrosis, but conversely have lower liver enzymes. There is a reduced seroconversion from E antigen positive to anti-E positive, so there's less likelihood of becoming an inactive carrier. And then if you are an inactive carrier, there is a much higher likelihood of becoming an E antigen negative chronic active hepatitis B. So HIV clearly has a deleterious effect on all the stages of chronic hepatitis B infection. Next slide. And so whilst, understanding the phases of chronic hepatitis B infection is important in understanding the natural history of hepatitis B, for a clinician, it really becomes rather complex to try and separate out all those different stages. And so we really ask ourselves the question, do we really need all of this complexity in order to understand treatment decisions? And in fact, in the most recent EASL hepatitis B guidelines of a couple of months ago, they say, well, really, look, let's not worry about how to classify people into the 4 phases that we talked about, but let's just talk about E antigen positive hepatitis B or E antigen negative hepatitis B, and within each decide whether the patient has chronic inflammation and fibrosis or not. And so this is tried to simplify issues quite a lot, so that for clinicians the decisions really need to be not based on the 4 phases, but based on whether there is inflammation and fibrosis and whether there is high replication of HBV DNA or not. Next slide, please. And so when we think about treatment of hepatitis B, we think about the aims of treatment. So the ultimate aim of treatment is prevention of progression to end-stage liver disease and death, and also to prevent hepatocellular carcinoma and prevent transmission. But remember, vaccination is also available. Next slide, please. And so the question that you ask ourselves, we all ask ourselves, is what determines progression to end-stage liver disease? So this is an important study called the REVEAL study from Taiwan, which looked at nearly 3,500 patients who were untreated, who had stored blood specimens, and looked at what predicts progression to either hepatocellular carcinoma or decompensated cirrhosis based on their initial blood specimen on which they measured HBV DNA levels. And what this slide actually shows is that the only single determinant of progression to end-stage liver disease in this study was your HBV DNA levels. And it didn't matter whether you were E antigen positive or E antigen negative. It didn't matter whether you had normal ALT or abnormal ALT. As an adult, HBV DNA levels are the biggest single predictor of progression to end-stage liver disease. Next slide, please. And so you can think of this in that analogy that we often use for HIV, which is a train running towards a canyon. And so in this context, your HBV DNA levels and your immune response to that HBV DNA is the size of the engine that is driving that train. And then a measure of ALT or inflammation on a liver biopsy is the speed with which this strain is traveling towards the canyon. And then the fibrosis stage is the time that you have left before you reach decompensation. And so all of these three become important factors in determining need for therapy. Next slide. And so what treatment is really trying to aim to achieve is moving people from the sides of that circle down through to the inactive carrier state, in the sense of getting your HBV DNA undetectable, and then if you're really lucky, getting anti-HBe seroconversion, and then if you're even luckier, getting S antigen negativity and seroconversion for anti-HBs. And then the ultimate aim would be to clear CCC DNA. All of these are increasingly more difficult with the current therapies that we have available. Next slide, please. And so the primary endpoints of treatment clearly are HBV DNA suppression, and then this leads to secondary endpoints of normalization of ALT, improvement in histology, anti-E seroconversion, S antigen loss, and anti-S seroconversion, in other words, antibodies to S antigen. Next slide, please. So there are a number of therapies available. This is a very simple graph looking at potency versus genetic barrier, and it's the three on the right-hand side of that graph that are the most important. The rest are now historical therapy, and so clearly the current therapies are Entecavir, Tenofovir, either as DF or AF, and pegylated interferon. Next slide, please. And so when do we need to start to think about hepatitis B treatment? This is balancing the risks versus benefits. Remember, for the vast majority of patients who are going to receive oral therapies, this is probably going to be lifelong therapy. And so one needs to think about the likelihood of an adverse outcome without treatment versus the adverse effects of therapy for a prolonged period of time and the risk of drug resistance. Next slide. And so there are three key interlinked factors in the decision to treat. Age, so the older you are, the more likely you are to progress to end-stage liver disease and hepatocellular carcinoma. Family history of hepatocellular carcinoma, your level of fibrosis and inflammation, and then HBV DNA levels, as we saw in the REVEAL study. And most guidelines suggest HBV DNA levels greater than 2 to 20,000 international units per mil should trigger thinking about treatment, especially beyond adolescence. Next slide, please. So there are many different guidelines available. I won't go through any of these in detail with you. You will have access to the slides, but you can look at these and you can see the guidelines mostly agree that the decision is based on HBV DNA levels and a measure of the transaminases or histological activity on a liver biopsy. Next slide, please. And more pragmatically, and I think of all the guidelines that we've seen to date, these are probably the most pragmatic, is the WHO guidelines, which look at all these three factors, age, ALT, and HBV DNA levels, to try and make a decision around treatment commencement. And as you can see, all of these things need to be kind of taken into account in terms of assessment for treatment. These guidelines are available freely on the internet, so please go and have a look. They're very, very useful guidelines. Next slide. So current guidelines recommend either PEG interferon for a finite duration of therapy of 48 weeks, or Entecavir or Tenofovir. Entecavir and Tenofovir especially are probably treatment for life unless you get anti-E seroconversion in E antigen positive patients or S antigen loss, which happens very, very rarely. And so both of these are long-term therapies, very much like HIV. Next slide, please. So for co-infected patients, this is a lot easier. You need to just include tenofovir or 3TC or FTC in their antiretroviral regimen. Next slide, please. So a question that a lot of you who work with HIV will be asking is, if we use single nucleotide therapies, what is the risk of viral resistance? As you can see down at the bottom, the risk of entecavir resistance is very, very small, and tenofovir resistance has not yet been described in the context of hepatitis B, and so those two become the most important agents for treating hepatitis B. Next slide, please. Unfortunately, lamivudine, talbivudine, and entecavir all have low genetic barriers, and so mutations can arise quite quickly in those three drugs. Entecavir is very much like a protease inhibitor in HIV, where it requires at least 3 mutations before you start to see entecavir resistance, so it has an incredibly high genetic, and that's why together not even high genetic barrier, these become very important treatments for hepatitis B. Next slide, please. Unfortunately, resistance to hepatitis B is expression is a very impression as compared to with virus or treated real and the associated expression to do patient. Next slide, please. Fortunately, is these mutants not only get the virus risk, it also changes in the S antigen of the virus, which region that controls the polymerization, and so what you get is called detection vaccine mutations, because it's the antigen which is used as faces hepatitis B vaccine. Single therapy. Next slide. And so and tenofovir is equally as good. As you can see on here, both work reasonably well, at least in terms of e antigen seroconversion for those that are e antigen positive. S antigen loss is lower both in e antigen negative and in e antigen positive patients, but the risk of resistance is very, very small. Next slide. So with that in mind, we now have tenofovir alafenamide. This is the tenofovir alafenamide TAF HBV Phase 3 program, comparing TAF versus TDF over a period of 144 weeks before everybody was switched to open label TAF at 25 milligrams. And on the basis of these studies, TAF has now been licensed for treating hepatitis B. Next slide. And as you can see, antiviral efficacy both in e antigen positive and e antigen negative patients is equivalent out to 72 weeks and beyond. So TAF is equivalent to TDF at suppressing HBV DNA levels. Next slide, please. Next slide, please. And perhaps a little bit more surprising for a lot of us that were looking at this data was that ALT normalization was higher in TAF patients than in TDF patients, both by ASLD criteria and central lab criteria. We're not quite sure what the reason behind this is, because HBV DNA suppression rates were equivalent in both the groups, but this may be a toxicity, a liver toxicity of TDF that had hitherto been unrecognized. And so watch this space, but TAF certainly works for hepatitis B. Next slide, please. And not surprisingly again, is that the changes in renal markers of proteinuria were better for TAF than they were for TDF, as we'd seen in the HIV studies. Next slide, please. And so when we think about the long-term outcomes of patients treated with oral therapies, this is looking at improvement of fibrosis regression. As you can see, right out to 5 years, there is fibrosis regression in those patients that had advanced levels of fibrosis. This is the reason why a lot of people who've been treated for hepatitis B with the oral therapies have come off transplant waiting lists. And so HBV DNA suppression is associated with histological benefits in most patients. Next slide, please. And this is the same thing out to sort of 6 years, and based on ISHAC fibrosis scores at baseline, as you can see, even those with very advanced liver disease had histological improvements, and again stressing the point that Hep B treatment actually does positively take people off transplant waiting lists. Next slide, please. But one thing very much like hepatitis C that we have to be careful about is that those cirrhotics that are treated successfully for hepatitis B, whilst you do get fibrosis regression, the risk of hepatocellular carcinoma, whilst reduced, is not completely abrogated. And so one needs to continue to monitor patients for hepatocellular carcinoma. Next slide, please. Okay, and then the last few slides just to finish off. And so whilst, at the moment viral suppression is the goal for hepatitis B treatment, very much like HIV, we now need to start thinking about functional and complete cures for hepatitis B. So functional cure, in its true sense for hepatitis B, is getting your immune system to control HBV viral replication to the level where your risk of progression to end-stage liver disease and your risk of progression to hepatocellular carcinoma is completely reduced. And so this would be the next stage. The complete cure for hepatitis B would be to get rid of all cccDNA from all the hepatocytes. And so these are the next two aims that we need to think about in terms of hepatitis B treatment and research. Next slide. And so this really complicated slide, and I really don't want you to look at this in any detail at all, shows you the number of targets that are available for therapeutics in the hepatitis B life cycle from outside of the hepatocyte in terms of immunomodulatory therapy to harness the immune system's activity against hepatitis B, to inside the cell where you think about specifically targeting the processes involved, not only in viral replication, but also in viral packaging and production of proteins. And so all of this are going to come through in the next few years as important therapies for hepatitis B. Next slide, please. One of the things that people have also often thought about is, can we combine what we have got currently, at least in terms of the nukes plus pegylated interferon, to see if that can achieve functional cure, in other words, tendering people S antigen negative. This was a small study that compared these therapies alone versus them together versus them done sequentially. Next slide, please. As you can see from here, this is S antigen loss at week 72. Tenofovir plus pegylated interferon for a year led to more S antigen loss in almost 10% of patients compared to either of those therapies alone or done sequentially. So this is perhaps one of the ways in which we can exploit viral cycle to try and achieve a functional cure. Next slide, please. There are several targets for directly acting antivirals for hepatitis B, including entry inhibitors, RNA inhibitors, capsid assembly modulators, S antigen production and release inhibitors, and then finally, very much like HIV, the degradation of the genomic material within the nucleus of the virus, so in other words, cccDNA degradation. Next slide, please. And so this is, where we're at the moment. Our current therapy is aimed at suppressing HBV DNA, and so this is your antivirals, mostly your nucleoside analogs. But there will be the next generation of antivirals, which will then add on to HBV DNA suppression. And the next thing that we need to look at is reduction in your S antigen production, and so this will need a combination of antivirals and immunomodulators, and with time we can hopefully reduce the cccDNA burden in the liver to affect complete cure of hepatitis B. So this is a schematic with which one thinks about hepatitis B cure in the future. Next slide, please. And so just to show you the pipeline that's coming through, as you can see, there's a number of agents, both in terms of immune modulators and directly acting antivirals that are in phase 1s, phase 2s, and some actually moving into phase 3 studies in the very near future. Next slide, please. And so I'm going to conclude by saying that, now that we're starting to understand a little bit more about hepatitis B, there is a new era in hepatitis B management that is emerging. The immediate aim we really need to think about is functional cure. In other words, rendering people S antigen negative off treatment. The ultimate aim would be to get sterilizing cure, which is complete clearance of cccDNA from all your hepatocytes. There's lots of molecules targeting host immune system and viral replication pathways that are coming through clinical studies at the moment, and we'll probably need combinations of these therapies in the future. There's also emergence of nanoparticle technology to try and package some of these drugs so that they can be targeted into the hepatocytes. What we perhaps need as an immediate is some emerging research and consensus in biomarkers and endpoints for hepatitis B research and therapeutics. And so I'm going to stop there and happily take questions if there are any.
Thank you very much, Sanjay, for this interesting presentation. So if you have a question, please raise your hand or write them down in the question window. I can see there's already one question, so I will just read it out loud for you, Sanjay.
Mm-hmm.
Does clearance of cccDNA damage the cell nucleus?
So yeah, that's a really interesting issue and a question. We don't have any therapies at the moment that successfully cleave cccDNA. But remember that hepatocytes are dividing all the time, and so that the daughter cells, some may acquire cccDNA, others may not. And so what we are trying to do is stop, at the moment, replenishing cccDNA in new hepatocytes. And so that, at the moment, is one of the ways in which we're stopping cccDNA populating new cells. Future therapies will certainly look at cleavage of cccDNA from hepatocytes, and we think and we hope without causing damage to hepatocytes.
Thank you. I have a question regarding side effects of the treatment options that you have been talking about. So what are the most common side effects, and to what extent do they constitute a problem for adherence of treatment of patients?
So in terms of the three currently available therapies, PEG interferon, Entecavir, and Tenofovir, PEG interferon that probably is associated with the most side effects of, as people know from their hepatitis C experience. I do have to say that there are very few places and for very few people that we would use pegylated interferon. Remember, the use of pegylated interferon is finite therapy, and one of its aims is to harness an immune response and hope that once you stop the PEG interferon, the immune response will take over and keep the hepatitis B at bay. In terms of Entecavir and Tenofovir, the side effects are very similar to what we've seen with nucleosides in HIV therapy. In other words, few side effects, but you know, some of the common things like perhaps a little bit of nausea and vomiting, etc., that one might see with nucleosides. Tenofovir DF in Hep B mono-infected patients, very much like HIV infected patients, is associated with a risk of renal damage and is associated with the risk of bone loss. So this is seen in Hep B mono-infected patients as well as in HIV patients. TAF, on the other hand, has fewer of these bone and renal effects.
Thank you. And perhaps you can tell us a bit more about the availability of these three drugs, these three treatment options in different areas of Europe, so in Western Europe and Central Asia and Eastern Europe. Do you have information about that?
Yeah, so I certainly know very much about Western Europe. So TDF and Entecavir are both widely available in Western Europe, and you know, and depending on price, one is preferred over the other, depending on where you are. TAF is starting to make an appearance as a replacement for TDF for hepatitis B treatment, and so this is something that is certainly emerging. I'm not sure about the availability of drugs in Central and Eastern Europe, and about the availability of generic Entecavir, although I do remember a couple of years ago, Andrew Hill did an article on production of generic Entecavir and suggested that Entecavir would be quite easy to produce as a generic.
Okay, thank you very much. Are there any other questions? If yes, then this is your chance to raise your hand or to type. I don't see any other questions. So thank you very much, Sanjay, again, for this very interesting presentation, for your time and support. Thank you very much also for your interest in this topic, dear attendees. And then I wish you all a good day, and yeah, talk to you soon at the prevention webinar. Bye.
Thank you. Bye-bye.